the idea behind this, this second, this is to present a collaboration that was created over the past sort of 2 years, and this event is co-organized by the University of Geneva, the NCD Policy Lab based at the University of Geneva, the University of Edinburgh, and the Steno Diabetes Center at Odense. As we all know, why are we focusing on the epidemiology of type 1 diabetes and really the link with the global diabetes agenda? So as we know, we celebrated the centenary of insulin's discovery in 2021, its first use in 2022, and that diabetes as a whole, type 1 and type 2, are one of the prioritized non-communicable diseases. However, most of the focus has remained on type 2 diabetes given the burden. We have the Global Diabetes Compact, we have a World Health Assembly resolution on type 1 on diabetes, and now we have this global target of 100% of people with type 1 diabetes have access to affordable insulin treatment and blood glucose self-monitoring. And so we need to measure this. We now have this diabetes prioritized research agenda, and the Lancet Diabetes and Endocrinology Commission on type 1 diabetes, and there'll be a side event at the end of today focusing on that initiative. So if we just focus in on this collaboration, so the Diamond 2A collaboration, and you'll learn more about why Diamond, why 2A, and why collaboration. So this all started with the question of how many people need insulin globally. And the answer was, at that time, we didn't know because there were no clear estimates on the number of people with type 1 diabetes. So together with Sarah Wild, with Anders Green and colleagues, we embarked on this adventure of trying to estimate the global burden of type 1 diabetes. As many of you know, there had been estimates for the 0 to 15 or 0 to 19, but there was never an estimate looking at all age ranges. From the reviewers, and as a researcher, we often ignore or prefer to ignore or don't take into account comments from peer review, but I think this process really opened up this question about how can we do things better, especially when we're looking at the epidemiology of type 1 diabetes. And with all that, with Anders, with Professor Kurt Hoglund from Steno Diabetes Center Odense, I submitted a grant to better understand the system in Denmark and what could we learn for low and middle income countries. And so I'm grateful for the Danish Diabetes and Endocrine Academy for supporting that work. And that led to an expert meeting as part of this project, which then led to a statement that many of the speakers today on the panel and speaking during this session contributed to on developing a roadmap to improve the epidemiology of type 1 diabetes. Following on from that, with support from the World Diabetes Foundation and in collaboration with the East African Diabetes Study Group, there was a meeting in Dar es Salaam to discuss how can this agenda move forward within the African context. Following on from that, we had a very small meeting in Geneva, and you can see some of the participants in this photo, from representing all WHO regions. This meeting was supported by the Swiss Agency for Development and Cooperation and co-organized by the Steno Diabetes Center, University of Geneva, and the NCD Policy Lab. And that enabled us to develop this concept that Anders Green will be presenting, and also this idea of this collaboration. We've had informal meetings, and hopefully today we'll expand this network. So really, the Diamond 2A collaboration is an informal network of academics and researchers, and you can see on the map, we still have a lot of areas that need to be filled in. We've had some online discussions, some meetings that people have participated in person or virtually, as well as webinars. I think what's important is that clearly the epidemiology of type 1 diabetes is important, and it's an important component to understand within the global diabetes policy environment, but that the idea behind this collaboration is to go beyond just epidemiology. The idea is to support research, to develop research training, to act as a clearinghouse for certain tools, and also develop guidelines. And I think what's also important for again, this small group of individuals is communicating and advocacy. So how can the data, how can the research that we develop be used for communication and advocacy as well as empowerment? So the agenda for this, this side event is I will hand over to Professor Tuomilito in a few seconds to give us some background on the diamond study. Then Professor Anders Green will present where we are with the Diamond 2A collaboration, and then I'll hand over to Morten Bjerregaard from the Steno Diabetes Center Odense to moderate a panel that includes many leading experts in this area, and then we will hand back over to Professor Tuomilito for some closing remarks. So with that, I hand over to Jaakko. Thank you.
Thank you very much, David. Ladies and gentlemen, good morning, everybody. Oh, good afternoon, actually. And I had to fly long way from Helsinki to here this morning to discuss about the WHO Diamond study. I go back in history. We had a first planning meeting of the Diamond study on 2nd of January 1990 in Helsinki, and there we designed the study and started to carry out the collaboration globally. Now the importance of diabetes registers was first pointed out at the meeting organized by Juvenile Diabetes Foundation in 1983, and there was a paper coming out talking about the geographic differences that were observed in the literature at that time, and this group was led by late Ron Laporte. Now the first attempt to actually do a proper comparison of incidence patterns of type 1 diabetes, we called it Diabetes Epidemiology Research International team, and we contacted people who had published something on type 1 diabetes epidemiology and asked them to provide numbers by age group and the population denominator data and so on a paper format. And we received the data from several populations and confirmed that so far Finland had the highest incidence. PEI means Prince Edward Island in Canada. That was the second highest, and then Sweden, Norway. You see that northern part, and that we did various comparisons like this one, looking at the temperature. But of course, this is a very, very, very poor epidemiology. But anyhow, that was the opening of the whole thing. Then we, later on, we started to look at the trends, and again, taking publications that had at least 10-year follow-up period, and we could point out that, as you can see here, that everywhere in Europe, the incidence was increasing, and it was so also in other parts of the world, even in Peru and China, Japan, where the incidence was very, very low to start with, but upward trend everywhere. Now, the Diamond project, as I said, started in 1990, and we invited people whom we knew to join this initiative. We presented at the different meetings, congresses, and so on, contacted individually people, asking them to join. We didn't provide any money, none, but Ron and myself put our department's money aside so that we could coordinate the work, and I had a data center in Helsinki without any money. So that was a Diamond project initially. Of course, I had the money, but it was my department's money that could have been used for something else, but I had decided this way. So at the end, we had a study ongoing and came up with a very simple definitions, because one of the problems was that there was really no definition how to define childhood onset type 1 diabetes. And as you can see, very, very simple way of defining, but we wanted to have a population-based studies. And at the end of the day, we had a database with more than 30,000 cases registered and more than more than 70 countries and more than 100 centers were included in this publication that came out then 2006 with the incidence data. While we were doing this work, Ron Laporte had a splendid idea, because we were concerned about the coverage of the case detection in these populations that were included in the study. And Ron identified an interesting methodology that has been used for many, many purposes, counting a fish in a lake or wildlife in African savanna or whatever, dog bites in the city of Copenhagen and so on. So you can use this sort of recapture method, and we promoted it to be used in type 1 diabetes epidemiology, because if the study was hospital-based, we knew that there are people who are using a private sector or different hospitals and so on. So none of the methods were complete, but using this methodology, we can count true number of cases using 2 or more methods to identify the cases. And with a very simple formula, we can come up with the number which is very, very close to the truth. And this we tested in various ways later on. Now the Diamond study provided the data, as shown here, for a large part of the world. But there were white places as well. Of course, Greenland is white because it's covered by snow, but also we didn't have registered there so far. Maybe now, when Greenland has become so popular, we can have them to be included in Diamond 2A. And so Africa, as you see, was missing. Middle East and Central Asia was also white. Today, we have data for many of these places, a little bit at least, but not very much. So this graph shows very clearly that there were more than 400-fold difference between the lowest incidence in China and the highest in Finland and Sardinia. So interesting was to see this huge variation. There's hardly any other disease where the incidence varies so much globally. If you can think another disease, please let me know. A Diamond study, high incidence countries here, or populations, because Sardinia is not a country. And that was a kind of surprise with the Eurodiap study coming up with the Sardinia highest. And then we had Kuwait in the Middle East with a very high incidence as well. But in principle, again, the northern part of European countries were dominating, or the British origin populations, including New Zealand, Australia, Canada. And then the low incidence countries, we could observe that many of these were Eastern European, so-called Eastern European countries, where they kind of called the Soviet bloc, and also much of middle or southern European populations. So there was a kind of a north-south gradient, but not complete. What came then to Asia, the one center in Russia, Novosibirsk, of course these are mainly the Caucasoid people living there. And Finland was part of Russia for more than 100 years in the 1800s and so on. And Siberia was used for criminals and other people to transport them there. And then also Stalin took a lot of Finns to Siberia, so that in Novosibirsk I went there and I could observe that there were quite a number of type 1 diabetic individuals with the Finnish names. Anyhow, so China also had a quite interesting variation in incidence, so it was not that everywhere in China the incidence is the same. And now they have additional studies have been ongoing. In South America, two types of populations. One's the populations like Uruguay, Brazil, Argentina, and so on, had a similar incidence as middle and southern European populations, whereas some other countries where Native American population is very prominent, the incidence is much, much lower. It's like in the Asian populations. And then North American population, I would like to point out here Chicago, because this Chicago study only included African American populations. But the incidence was about the same as in general in the United States, other parts. And then finally, Oceania, Africa, Near East, as I said, the countries like New Zealand and Australia had a similar incidence as UK in general. And then Northern African populations had very close the same incidence as Southern European populations. So all these things gave us also to look at the possibility to look at the time trends, and what we could observe that everywhere, all regions, the incidence was increasing during that 10-year period, and the incidence was more or less about 3% per year. And this was quite interesting to see that everywhere it went up. Now I come back to Finland. We had data since mid-1960s nationwide, and you can see that the incidence have been increasing in a very, very steady fashion. No ups and downs, no epidemics, it's just going up. And that must tell us something about the reasons that it is not that there is a kind of a virus epidemic and then a lot of cases and so on, as it has been sometimes by some people contemplate. But later on in the 1990s, the incidence became even steeper. Whereas the study that was published about 5 years ago was questioning whether the increase has been ended. But if you look at this graph here, the plateau was only seen in children aged younger than 5 years old. Older children have a rather flat trend, but no decrease definitely. We'll have to see more years to come where we are going. But we have a new data then from various parts, especially Graham Ogle has been very active with his organization to map the incidence in the various places, is Maldives. And I would like to point out that one fact here, that when you start the incidence study, the incidence may be rather low, and it's increasing because the case ascertainment is improving. And that's why we need a capture-recapture methodology. So I would see that in the middle of this time trend, after that, the increase in incidence is not anymore very steep. Now, what happened in a high incidence country, Kuwait, is shown here. Increase has been seen in all age groups, and especially in children aged 5 to 9 years old. So high incidence population, just like Finland, Kuwait also has seen the steep increase. Another phenomenon that has been described in the past is the pre-pubertal peak in incidence, so that children aged 11 to 14 years have the highest incidence. You can see here two populations, Sweden in the 1980s and the 90s, and China more recently. Both of them showing a similar pattern. The other thing here, you can see that there is no difference in Sweden between boys and girls in incidence, except when they become adults. Now, this is the global analysis showing again this peak in the pubertal ages. But when we observe data from Finland, there is no more this kind of peak. The incidence is already very, very high among 2 to 3-year-old children in our country. No more pubertal peak. So the pubertal peak, which was contemplated to be due to hormonal changes, it doesn't happen here. So that must tell us something, that these hormones may not be critical. They may, in some situations, be important, but not necessarily. But why is increase happening? There were two different hypotheses pointed out. Accelerator hypothesis, so that there is a risk factor which is gradually increasing, or a so-called spring harvest, that the age of onset is becoming younger, but if you take a lifetime cumulative incidence, then there is no difference. So, which one is true? Maybe obesity has increased an incidence a little bit, but the effect is relatively weak, whatever data are available on that. A spring harvest hypothesis, no evidence whatsoever. In Finland, for instance, we see increase in incidence in young adults below age of 40 as well as in children. Now, finally, one thing which I believe is important is genetics. We looked at the twins. We had 13,000 twin pairs, and we looked at the concordance among identical and non-identical twins, and then using a twin research modeling system, we could estimate what is the contribution of genetics here, called A in the model, or environment, which would be primarily E. Now, the model came out that more than 80% of the risk comes from genes, and only about 12% from environment. And the same was, similar results were obtained from a Danish twin study as well. So here we are. The genes are there. Why the genes could be reason for an increase, better survival, and contribution of families. And then in our twin study, for instance, the concordance rate was only about 30%. So 70% of identical twins whose co-twin had type 1 diabetes, 70% of the other twin didn't get the disease, but could transmit the genes to the next generation without the disease. So with this, I would like to conclude that we have, over the last 40 years, obtained a huge amount of new data on type 1 diabetes incidence, but still less than 40 countries in the world are providing a new data on the incidence, and that's why we need a new collaboration. So, as I pointed out, we don't know why the increase in incidence happens. There is no single environmental factor which has been proven in all populations and all studies. Many of them have been attempted to call the critical reason, but none of them have been proven. So, again, the global Diamond 2 study may be able to provide databases and study designs where we can identify better the causes of increase. Thank you very much.
Thank you very much, Jaakko, for that history of the type of epidemiology of type 1 diabetes, and also just highlighting that although we've studied a lot, there are still many questions. So I'll now hand over to Professor Anders Green, who will tell us a bit more about the rationale and why this new collaboration. Thank you, Anders.
Thank you, David. Now, you talked about the timeline and the history of the new diamond, and Jaakko has talked about the history of the epidemiology of type 1 diabetes. I'm going to briefly review what we suppose Diamond 2A is about, and I'm going to spend a little bit of time on the new data we are going to look at right now and in the future, if I can make this work. How do we get ahead with this? This one. Sorry, this goes too far. Too fast. Well, here we are. Come on. Yeah. First of all, even though Jaakko has explained what we know, we still need better data on type 1 diabetes. And we need particularly data about the prevalence and mortality of type 1 diabetes. And particularly, we know little about what the situation is in patients growing up with type 1 diabetes and become adults, and we know little about what is happening in terms of incidence in adult people. We don't know much about trends over time in incidence when we come beyond childhood. And why do we need all these data? We need it because it is necessary to put type 1 diabetes on the health agenda internationally and in each country, because type 1 diabetes has a tendency to drown in the quantity of type 2 diabetes, and in many developing countries, type 1 diabetes will compete with other major health impacts like infectious diseases, etc. But still, type 1 diabetes has this specific feature that insulin treatment and supporting care is absolutely necessary for survival, and therefore there is a moral obligation for society to put it on the health agenda with more emphasis than what is happening right now. And the meeting today and the next days will actually be focusing on that. So we need better data for advocacy and stakeholder engagement in type 1 diabetes in order to secure access to insulin glucose monitoring instruments and to supporting care in diabetes. Now, just to take a short-term trajectory of what has led to the present situation on Diamond 2 collaboration. Some years ago, we started to see the emergence of type 1 diabetes global metrics in model data because the lack of empirical real-world data, it was necessary to build model. And there have been existing now several models that differ very much in size of estimates, and that actually formed what David talked about, that we needed to sit down and see what can we do about it. So there was this meeting in Geneva in November 2023, where actually it was a very seminal meeting in the sense that we managed to outline a master plan for a new kind of collaboration to stimulate further activities and research in type 1 diabetes. And it also led to a very instrumental letter commentary in Lancet Diabetes and Endocrinology that came up later. And therefore, we are now standing with the present organization or collaboration we call Diamond 2A. You may ask why 2A? Somebody would call it 2C. We mean 2A for 2A. A means action. So it's Diamond version 2 action, and it's a collaborative network. So therefore, Diamond 2A collaboration. It's difficult. Somebody would call it differently. Okay, but what we are talking about here is an informal network. We have no strict management. We have an informal structure. We have online meetings where we have regular and periodic meetings for interchanging information of various relevant kind. We have webinars coming up, and we are supposed to organize training seminars, which I'll get a little bit back to, and we want to collaborate and make structure of collaborations in terms of various work packages that are addressing different aspects of future work in type 1 diabetes. So we have in what we conceive is the current and future of Diamond 2A collaboration, we have three major pillars here. The first one has to do with research. And basically, you have research of various levels. You can base your research on concrete studies, surveys, short-term studies, case stories, etc. And in the end, if conditions permit it in the individual countries, you can set up national or regional registers, which we hope can be stimulated by this, but it may not always be the case, and therefore we have other means also to get more and better information on type 1 diabetes. But in addition to that, we need to build up and increase capacity in actually providing better data, capacity building in research and translation of research into the society. And we are talking about making supporting networks locally. We are talking about twinning and sharing experiences across groups, individuals and countries. And we are talking about provision of guidelines for research in these areas so people can actually take some manuals and start doing research locally and regionally. And also we need to improve advocacy and increase advocacy with a purpose to improve care in diabetes, and we can do that from the network by means of producing reports at national, regional, and even global level, and produce publications and other scientific reports, and actually trying to translate developments in these areas into stakeholders and other aspects of the society outside the research area. That's very important, the last thing. So we have these three pillars which I just mentioned. Now, this is where we are. We have three actually series of events here. We are actually setting up regional webinars in order to inform about Diamond 2A. And this is happening now, but these seminars, they are tailored to regions according to language and according to what is relevant for that particular region. That could be in Asia, in Africa, in Europe, etc., and South America and Central America, for example. So it is working now. And the purpose here is to inform about the Diamond 2A as a collaborative network. It's also important to actually try to recruit new participants in the network activities. So it's a matter of upgrading, stepping up the network. The other thing is, and this is also ongoing, that David actually coordinates periodic, very informal, internet-based meetings where we exchange results, exchange news and new initiatives, etc. So people can join if they wish, and they can leave if they wish, but they can get informed about progress and what is happening in next and what could happen in terms of funding, etc. What we still need to establish, we need the funds for that. That's a kind of central organization. It is important to stress that we consider Diamond 2A to be a bottom-up approach where all the work should be done in work packages. That's the real thing, but we need a little bit of central coordination to actually have a homepage and control a homepage, and to serve as a kind of coordinator for repository of data collection and relevant literature and manuals for instructions for research, and also to support the coordination and reporting for the network as such, but also for the surrounding world and translational aspects of what is coming out of the network to the society. So these three pillars and these three activities, they are actually ongoing, except that we need a bit of central coordination. Now, the very important part of the Diamond 2A activity is research in the epidemiology and public health aspects of type 1 diabetes. And I want to spend a few minutes on where we are right now, bringing it further from where Jaakko left his historical background. This is just an illustration. I don't want to spend more time on that. This is what we know about childhood and adolescence type 1 diabetes incidence rates, and you can see the variability and changing over time in most countries. Nothing new here. But what we don't know is what happens in the adult population in terms of incidence, what happens in terms of mortality, complications, what happens in terms of prevalence, which is the most important figure when it comes to public health aspects of type 1 diabetes. And also, we need to consider, when we talk about diabetes type 1, is that the same disease in all countries? Or have we different manifestations, which we call type 1, depending on where we are, whether we are in Europe or in Africa or in Asia? That has not been discussed fully so far, and that's an activity that could be taken up by Diamond 2A. So this is where we are. Now, I'm spending a little bit time now on what has been published recently about model data of type 1 diabetes epidemiology. What you see here is estimated global incidence case numbers on an annual basis. The lightest column is for year 2017, and the most dark columns represent projections until 2040. And you can see the type 1 diabetes index. They are coming up with new data, but you can see in terms of situation in 2017, the type 1 diabetes index, the data we published in 2017, the global burden of disease estimates from 2007, and our new model, they are more or less the same in terms of incidence numbers. But if you go to the projections for the future, you can see a twofold difference in numbers. And I think this is important to understand, that there are so many differences between the global estimates that we need somehow to find out why is it so different. Because if we're going to use it for advocacy, we need to have more reliable data which we can trust on and we don't have to fight about. So this is one reason that we need to look more carefully about model data. It becomes even worse when we go to prevalence data. If we look at estimates at the global level for prevalence in case numbers each year, you can see that the type 1 diabetes index, they are supposed to go from nowadays a prevalence about 6,000 if you go back to the year 2017, but up to more than 1,000, but millions, we're talking millions here, but up to 16 millions. That's more a doubling. And I don't think that I don't understand the explanation. The WHO, we didn't project anything in the future. I haven't found projections for the global burden of disease data, and our new model is much more modest in terms of what we see as a new prevalence, because we don't believe that the incidence will increase so much that it could create such a high prevalence that the type 1 diabetes index assumes. But again, we have the same comments to be made here. And that is, we have this huge variability between the various estimates, and it concerns the current prevalence level as well as what is going to happen in the future according to our estimates. So we have room for improvement, and we need to find agreement about how to extrapolate from missing data and how to actually make trends for the future incidence and how to translate from incidence to prevalence. So I'll jump, these slides represent actually what Jaco said before. I'll just end up with our estimates for the future incidence. You can see we expect it to more or less stabilize, so we are ending up with 370,000 cases annually at year 2049. Particularly in the low-income countries, the number is much smaller than the global. It's much smaller contributions to the global, but the increase is relatively higher. In terms of prevalence, and we can see that the middle line, now I'll jump this for time reasons. What I'll show here is the green lights indicate what has been gained of life years due to insulin treatment. And you can see a substantial increase, but the numbers of lost life years due to lack of insulin and excess mortality is higher, and it will become even higher. So there's really a room for improvement of care for diabetes, so the prevalence will increase. So I'll conclude here and say that we have a lot of information we can transmit from the Diamond 2A collaboration, and we need still to have more real-life data, and we need to do it globally, regionally, and nationally. We need to align assumptions and methodologies when we model data, and we need to use these data, bring it into play to the society. And the Diamond 2 network hopefully will provide a means to serve these purposes. I think I'll stop here, David, and leave it for further discussion.
Yeah, thank you, Anders. So I'd like to introduce myself. My name is Morten Bjergård Andersen. I'm a medical doctor. I'm an associate professor with the Steno Diabetes Center in Odense and the University Hospital of South Denmark. So, and I'm part of the Diamond Network too, representing, like Anders, Steno Diabetes Center in Odense here in Denmark. So I'll be moderating this this panel, the discussion, where we have some leading international experts within the type 1 diabetes field. So yeah, I think in the interest of time, we better get started. So I'd like to invite the panel guests to come join me here at the stage. We have Dr. Basit Professor Basit from Pakistan, and Dr. Mayaliva. Here, yeah, welcome. And Professor Bahenka from Uganda. And also Sarah Weil from Scotland, University of Edinburgh. And Jill Farrington from the World Health Organization. And Mads Loftager from the World Diabetes Foundation. And, sorry. Is anyone missing? Yes, Dr. Bande. Yeah. Okay, so welcome. So I think one of the issues regarding the diamond collaboration is that we need better data, but what for? So obviously we have an idea why it's needed, but is it mainly for clinical purposes to direct us in our daily patient care, or it is more like epidemiological data, like Anna showed before? We can see maybe increases or decreases in trends. So is there anyone from the panel who would like to elaborate? What is the most needed part in terms of data? Because at least an initial part of the Diamond 2 collaboration is about improving our data. We have more extensive goals than that, but yeah, Sarah.
Thanks very much. I hope I pressed the right button. Really good question. It's something that I get asked a lot as an epidemiologist of what's the point of data? Is it just stamp collecting or butterfly collecting, some people call it. But I like to think not. I think it can be used for a lot of purposes. And you mentioned two of the key ones, Morten. I think it's really interesting with the World Diabetes Compact that if you're going to measure whether everybody with type 1 diabetes has access to insulin, you need to know how many people there are with diabetes. So starting from one angle. But you mentioned also data for clinical care, and clearly it's really helpful for treating individual patients to be able to have good records. And so very often, in Scotland at least, the way the population-based register started was from care for individual patients. And then because it became widespread and used for all patients, then we ended up with a population-based register. So I think it depends on your perspective as to which is the most important. They're both valuable uses of data.
Thank you, Sarah. Anybody else who would like to comment on that? Yeah, that's it.
Thank you very much. I think I'll agree with what Sarah is saying. The data we need to also help in planning, and we know the numbers, so probably if you have the data, it's easy even to plan for them for the insulin we want, and it's easy to monitor them and see how they are improving, and if you are taking really good care, and what we're doing, what we're doing is really fruitful, and that's. I think that's what we'll use that data for. Yeah.
Thank you. Yeah, Mads?
Yeah, to agree, but maybe add further details, I think, on both points, both on the quality of care and the importance of data for that. We have been supporting a project in Rwanda in recent years where we've helped to develop a registry for patients with type 1 diabetes. My colleague Natalie, who sits down here, has been supporting that. And some of her initial data coming out is that they've seen an increase in the number of patients with HbA1c levels within the agreed range, increasing from 41% to 73%. Mm-hmm. And that's, we should not be conclusive on that, but it's an indication of either that it helps to improve the regimens, or that it just helps document better than previously. Yeah. So from that angle, we see it as important, but of course also global epidemiological data, because from the Africa region, which I cover myself, there is so little data. So even understanding the extent of the problem, we saw it in the projections that Anders showed before, that there are so big variations because it's projections, it's not data.
Yeah. Yeah, Silva.
To add something so that we sort of merge the various sessions we've had. If we look at what's transpired in the previous session, was that in disaster preparedness, afterwards integrate the people you receive who have been in disaster with the current or with the programs running in the country so that we reduce the rates of complications. But if you look at our data, that is the importance of data, with the present programs running, particularly in the low-income countries, they're already running at levels where there are complications. So you are actually getting another group, merging with another group, only to merge the complications with another complications. Mm-hmm. So that's the importance of data. One might say, oh, these ones are coming in because they already have complications, but actually you already have complications if you actually have comprehensive data. So that's the importance of data. Whatever you are looking at, we need data to be able to know what's happening to our population with diabetes.
Yeah, obviously, I agree. But I think one of the main issues that we need these data, and as we've seen on the map, there are many parts where we still we don't have a very clear idea what is the type 1 diabetes incidence, what is the prevalence, and so on. But another real issue is taking the data and improving the individual care for the patient, and that is sort of like the missing link, so the big step that we need to take. How do we improve the lives of some of the specific people also we saw earlier today? So yeah, we need these. I've been interested in the COVID pandemic, if that could have sort of like accelerated the type 1 diabetes development, and obviously that is epidemiological data is important in that regard. But the real issue is improving the lives of the people. So this is also what the Diamond 2A collaboration is about, is action in order to facilitate care and patient advocacy and so on. So maybe some of the other panelists would like to. Yeah.
First of all, thanks for inviting. I take the points, all of the points which has been suggested by my previous panelists. Just to add on in Pakistan, the only study we had for incidence of type 1 diabetes was in 1994, which Jaco was showing in 0.7, the data was at that stage. So 1994, we have no other data for type 1 diabetes. So that's the importance of having a data now for incidence of type 1. On top of it, I don't know how many in the house, but we are in Pakistan seeing a lot of childhood obesity and type 2 diabetes coming along at the same time of ages of 10 and 12 and 14. It's a diagnostic dilemma. So perhaps at the same time, this data analysis and this registry or this looking for incidence of type 1 may also help out to find out what are the indicators which decide whether it is type 1 diabetes or type 2 diabetes at that young age. Thank you.
Yeah. Yes.
If I can add and complement a little bit, again, thank you for inviting me. I think for having better data on the quality, we need, as Anders was mentioning, also global metrics, so standardize both data collection protocols as well as global metrics that allow us comparison. On the coverage side, of course, encouraging an international collaboration, as for example, Diamond 2A is already an important starting point. And two other important things, if we want to translate this into clinical practice, is actually enhancing clinical decision-making, so translating what we obtain through data and registry and estimated that we made into actionable insight. So never forget that the data that we have, even though those are estimated, might be not 100% reliable, there's a need to communicate those data, also to have a validation at country level. So those data should be validated, and it's our responsibility as researcher or public health professional to really improve the quality of those data. And one last point I think very important is the data health literacy of the ultimate audience that we have. Because if we consider estimate, we should be able to understand what those estimates are telling us. At the same time, as country representative or working in a specific country, we should validate this data, we should provide feedback. So I think there's really an important message on really improving the capacity building that Anders was talking about on data health literacy among a broader audience. Thank you.
Yes, Diallo.
Thank you. I guess it's also around if I give the example of WHO in terms of advocating for the importance of health information and monitoring systems, and trying to make clear that data should also be used for evidence-informed policy. It shouldn't just be data for research. And I guess one of the roles of WHO and in my own work is trying to bring together policymakers, researchers, clinicians, people with diabetes to actually see what different types of data exist, how these can be triangulated, and then how they can be used to give a powerful argument and advocacy within the country. Getting the data from just the researchers, but to show that there are many sources of data and they can be used. And I think you've also made the important points about the limitations of the modeling of data, but I'd also look at the power of having data from within a country, even if it's limited. So many of the countries I work in, they have paper-based records, they don't have great capacity in terms of university or academic support, but even just using clinical audit, looking at the quality of care, demonstrating what is possible within a country, what are some of the limitations, can be quite powerful with policymakers and other colleagues.
Thank you. Yeah, Silva.
Thank you very much. Yeah. Thank you very much. Let me go back a little bit so that I can take the audience through what would happen with low-income groups in particular. One is who is going to collect the data right from the source. We are looking at training the health workers because you may not have sufficient funds to get someone who has been trained. You are going to depend on the government, and the government is going to have health workers at primary health care level. So we are looking at who is going to collect the data and where is the data going to go into? Is it going to be paper-based or is it going to be into a digital tool? Now, I had asked Ben to project a slide. If he can, he'll project it later, and that will help as an example. So I'll give an example of Uganda. And when we started way back, we started with electronic files in 2009 as opposed to using paper files. And the problem was everyone was afraid of you seeing the computer. So that was problem number one. So getting them now to learn to get to using the computer system or to using the digital tool is a barrier. That is at the bottom, at the grassroots level between the patient and the health worker. So we need to get there. Once you are there, then what data are they giving you? Are they giving you centimeters to 0.1 or centimeters to 1, or weight as it is? Somebody is sitting on his waist, going onto the scales with his shoes and coat and everything. the years, are they knowing the age or are they estimating the age? Are the parents the same or their parents in a clan? So there is that need. Is the data uniform or not uniform? So one has to look at that, and yet when it has reached at the end, it's aggregated, you may not even tell the difference. So we need to look at that. Then when it has moved, in which way is it going to move? Digitally or through an Excel, and then the Excel transferred, in which mistakes are going to be done. In Uganda, we started then using the tablets at the health center level so that there is minimal issues. But then you also compete with government as to who is going to enter data, and everyone wants the person who is entering data there to enter data into their own system, either a digital tool or paper-based, so that the health worker now is overloaded, and at the end, you get poor data. So when we've finished all that, and then you get the data, who is going to use the data? Is it going to help the patient? Is it going to help the health worker? Or is it going to help the researcher? Or is the data going to be used by the Minister of Health or by the people who are interested in knowing the prevalence of type 1 diabetes and the funder who is giving me insulin and so forth? So all those have to be coming in order that you actually have a way of collecting data so that you satisfy all the groups. So at the end then, you sit down and plead to whoever is with the government and say, I need this data for this and this and this. So that is how we probably would be looking at it in developing countries, that the system is not yet well uniformed. We have people collecting data, they may not be very well, so they may need a training, or better still, to define what data, what accuracy of data do we need. Otherwise, we may be collecting a lot of data that has a lot of inaccuracies in it. Then at the end, we should not forget that the data collected needs to be helping the patient down at the grassroots to be able to continue, and that the person collecting the data is equally satisfied that the data they are collecting is helping them, and they need to collect more accurate data. I think that's the message I want to give.
Yeah, and I think, as Matthew also pointed out, these electronic registries that are being created in various parts, they're extremely important. Sometimes people may show up and the names are spelled slightly different, or the age is not entirely correct, and there can be problem with duplicates and things like that. If you have electronic registries where there's a unique identification number and that sort of thing, it sort of like increases the quality of the data that we are using. So that's one challenge, or something that we will have to look into in terms of this Diamond 2 network that we are inviting basically all countries to join, because the more data we have, the more certain we will also be. And yeah, maybe you'd like to.
No, just to speak a bit more into what Silva was outlining here, and yeah, with the example of Rwanda, and the importance of electronic data, but also the huge task of getting there, because I think what's possible in Rwanda is that it's been the Rwanda Diabetes Association that's developed this tool as a parallel to the public registration system, so to say. And therefore it's been possible to do relatively quickly, and with very hands-on consultation with nurses involved and so on.
Yeah.
But it's a diabetes association tool that tries to help the public health system. But in reality, it's the same as what I've also witnessed in Uganda, is that you then mean that in the facilities, they have to register 2 places. In the public, which is still paper-based. Well, okay, in Rwanda it's transforming, but in Uganda it's paper-based.
Yeah.
And of course, that's the healthcare professionals, that's the first they're going to be kept accountable for, is what they have to put into the official. And then they have to do the double registry. So the point I'm trying to make here is that developing an electronic registry with the ministry for the public health system is a long journey. So you need other stakeholders involved to help to do some immediate solutions until you reach that endpoint. And that's why I think it has to be this partnership between also associations or others that can support the government.
It's a long journey in many places. So, and one thing we have not discussed yet is the whole definition of type 1 diabetes. I mean, how, as an endocrinologist, mainly working here in Denmark, I have this idea it's a young, lean person, and you definitely have to measure these autoantibodies. But that may not be the interpretation in all settings. And this is also something we have to keep an open mind. And Anders addressed it a bit in the beginning. What is considered type 1 diabetes in the various settings? So yeah, it's an interesting topic. Would anybody like to address that, or? Yeah, Sarah.
Oh, please go.
I'll just first second what our colleague has said regarding registry and whether the government or the public sector will be able to take this burden on their own in many low middle income countries. So I've got an example from Pakistan where we have established an NGO which is called Health Research Advisory Board. And this board has been running for the last 12 years and 13 years, and I just happen now to be the chairman of it. And one of our flagship projects is to develop disease registries. And so that is helping the government now, and we are taking the registries we have developed to the ministry, that this has been done already, and this is the way we have been trying to develop the resources, etc., of infrastructure for the registry. And now only matters for the government to endorse it, so that at least it becomes a national level document. So sometimes you have to take initiatives which may not be to start with government-based, and you depend on the resources available and the multiple stakeholders available who can play their roles. And then the government takes interest in it and comes in and say, okay, we are going to endorse it at the national level. Now, coming to your question of diagnostic criteria for type 1 diabetes, especially in places where autoantibodies, etc., are not easily available, or the genetic studies are neither available, then in that case, we just rely mostly on clinical symptoms and the way the children present with type 1 diabetes. That's usually not the norm in our parts of the world to diagnose type 1 diabetes. The major we can do is at times C-peptide levels, which is also not widely available, but not more than that at places. Thank you.
Thank you. So, that was some of the points that I'd like to address. So, yeah. Yeah.
Don't worry. Yes, while you're finding your notes, I think Abdul's actually said what I was going to say, but I think just reassuring perhaps other countries starting off with registers, it does take a long time, even in high-income countries. And before the first things are to try and get a small amount of data collected well. And even in Sweden, they had double data entry for many years, which is such a waste of effort, I think. Fortunately, in Scotland, when it was set up, it was a single point of entry. But yes, so even in high-income countries, registers are difficult to set up. So I'm really reinforcing the point about being patient, about setting these things up. And it's maybe people here's children who'll benefit from it, and grandchildren for some of us. But and then to the point about what is type 1 diabetes, it's a really difficult question to answer. But as Abdul said, in Pakistan, there's an increasing incidence of type 2 in younger children. And it would be a real shame to have separate databases for type 1 and type 2. So I'll rely on others to think about how you might define type 1. And in Scotland, even, we have a clinical diagnosis of type, but when we're using the data for research purposes, we try and clean that up with the information we've got. We don't have widespread measurement of antibodies or C-peptide either, so we have to use other information like time to insulin after diagnosis, so it'd be imperfect. But again, as the register develops, perhaps against type 1, you might have on what basis was this made? Was it ketoacidosis, etc.? So that's a bit advanced, I realise. Probably at the beginning you just want a diagnosis of diabetes when you're starting.
Yeah.
I just want to also follow on the idea about a registry being a long journey. So a registry might be a long journey, it might not be feasible, it might not be sustainable in a country. But what might be a shorter journey is digitalization of the health system and the health information system. And that I think the academics and the clinicians need to make sure that they are influencing. Because we've found that in some countries, it's software developers who are working on that, and they're not necessarily taking into account how that data needs to be used by clinicians. So one of the countries I work in, Kyrgyzstan, over 2 years, we were doing capacity building exercises with the people developing the Centre for eHealth, where we were bringing together the clinicians, the specialists, the family doctors, and people who were entering the data, academics, universities, and looking at what did they need, and just running through extracting data, seeing where some of the limitations were, the problems in that, how were different people going to use it, and then 2 years later, some of that system's improved, and also that the people, the clinicians are actually using that data in meetings with the Ministry of Health and also in their own research. So it was a 2-year trying to influence the development of something that was happening in the health system anyway.
And then you have the whole problem with knowing the denominator. Sometimes people come from very close by, otherwise, in some other cases, they travel long just to have this type 1 diabetes appointment because they may trust the doctors more at the referral hospital. So that is also part of mapping the incidence. But Dr. Amosita?
Yes, thank you. And I fully agree both with Sarah and Jill. I think the importance of communicating back to clinician, sometimes for health professional, the data collection might be seen as an additional burden on their work. So I think providing them with the feedback of what they provided through the data and how this data can actually be used, I think is really key. And another 2 points that I wanted to highlight is the experience that we are having actually in Italy within a joint action on cardiovascular disease and diabetes named Giacardi. We are actually developing regional diabetes registry, and I was listening on how to develop the registry, and I really can be more in line with the need to be patient. We were in a different position because we had a strong political commitment on developing the diabetes registry, and also the funding to do that. But at the same time, I think the sustainability in long term and having the political commitment is really essential. And another point was on the definition of diabetes. There's, of course, based on the possibility, the availability, the resources that a country has, it might be difficult to detect antibodies. I just wanted to report a pilot study, a pilot project that in Italy has been implemented in the last year. With a political commitment, there was an establishment of a law in which we actually started to screen pediatric population on type 1 diabetes antibodies and celiac disorder, so that we might detect also an early diagnosis to avoid, the main aim was to avoiding mortality for ketoacidosis or the health outcome on ketoacidosis. So this was another point and maybe interesting project that I wanted to highlight from my country, from Italy.
As I understand, you've been comparing some modeling data from Italy with the real world type 1 diabetes, so like what you record in the clinics. Could you elaborate on a bit? Do the numbers add up, or?
Well, I also like to have a discussion with Anders on that. So I was working on the global burden of disease estimate, and we try to compare. We compare with the primary real data from a regional registry in Italy. What we observed that we actually compare both type 1 and type 2 diabetes. As Sarah was mentioning, there's this really striking trend also on type 2 diabetes among adolescents. We were focusing on this study population. And for type 1 diabetes, we actually observe a quite good alignment between the GBD estimate and type 1 real data from the regional registry, even though the GBD overestimate the numbers. And the main thing is that the data sources that have been taken actually to develop this estimate were data from the registry and literature that were based on this registry. So the alignment was quite good, both in prevalence and in incidence. For type 2, there was a huge discrepancy, and this is actually also related to difficulty that the GBD has in estimate type 2 diabetes. So they model separately the total diabetes and type 1. Type 1 is actually, type 1 is mainly based on incidence data, as Anders was perfectly mentioned earlier. So what we observe is actually the need of validating modeling data and also the complementarity of both model and primary data. So those approach can actually communicate to each other, needs to communicate to each other, and primary data should validate the model. And we also understood actually that we observe the need of improvement of primary data for that study population in the regional diabetes registry. So it was a mutual benefit from the model, for the model and primary data.
Could you access some data regarding treatment? Were the persons on insulin or?
I was mainly prevalence and incidence, yeah.
Okay, yeah. You would like?
Okay, thank you. I would like to add from what everyone has said. Somehow we have to start somewhere, depending on where we are. Like in Tanzania, where most of the part is digitalized, they're using a system. We can borrow probably from Diamond 2A and get what are we collecting. So who are we collecting for? So from the Diamond 2, we might collect data which is universal and it's standardized for the clinician, the patients, the policymakers, and for everyone. Remember, these are people who are seeing patients with diabetes, with HIV, with malaria. So we need a minimum data that can be used by everyone to plan for policy, for epidemiology, and I think that is possible if we standardize for everyone.
Are you seeing more type 1 in Tanzania? Is it increasing? Is it your clinical impression? Or?
It is increasing,
okay.
And we are calling them quote unquote type 1 because they are presenting fast.
Okay.
But sometimes they might stay for a long time without insulin, and you're wondering, are they really type 1? So
yeah. Yes. So I think we are about to wrap this session up. I don't know if there are any questions online or also from the audience, of course. Yeah. Yeah, please. I think the mic is coming.
Thank you again. I'm Professor Bishwajit from Diabetic Association Bangladesh. I have two questions. First one is, the first two speakers, say in their presentation, they showed the high prevalence rate in the high income countries and the coal countries. How do you explain this association? And the second one is prevention of type 1 diabetes. Is it reality or this fantasy? How do you explain?
Sorry, the last part I didn't
prevention of type 1 diabetes, is it reality or fantasy? How do you explain?
Okay, yeah. So, any...
There were questions for you two. Speakers. Yeah. Well, shall I try and answer for Jaco and Anders?
So, well, just I'll just wrap up the part regarding the cold countries, the warmer countries. There has been this this theory regarding viral infections that sort of like can trigger type 1 diabetes development. I think sometimes these respiratory infections are more common in colder climates, but obviously that hypothesis can be challenged too. You have but yeah, type 1 diabetes, the prevalence seems quite high here in Northern Europe, but then again, then you have Sardinia, and so there are many other factors as well, genetics, and it seems to be maybe in some Asian countries lower, but it's quite complicated here, and when we just have so little time. So yeah, I don't think we have time for more questions. We're already 10 minutes over, but yeah, thanks to the panel.